This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Today it's my pleasure to actually get to talk with you about one of my favorite subjects, which is vaccinations. And as you'll be able to tell as we go through this talk, I am a fan of vaccinations. I think vaccinations are a very good thing and a really helpful and a public health advance. But I think one of the things that you'll also appreciate, I'm going to try to give you a balanced approach to vaccines, because vaccines are not perfect. They have some problems associated with them, in addition to the advances that are associated with them. And so I'm going to try to point out what we know, what we don't know about vaccines, and where they've really helped us out the most. And I have no conflicts of interest to disclose. Actually, I don't have very much interesting to disclose, so we will continue. So I'm going to talk today about preventive vaccines. There are also therapeutic vaccines that we're not going to cover today, but you may have read about them or heard news stories about them, and those are also very exciting. So for example, in some of the cancer fields, there have been a number of advances where people have used vaccinations by immunizing people against their own cancer cells and using them as cancer treatments. But those are very individualized therapies. And the vaccines we're going to go over today are actually the general vaccines that are available to the public. And because these are given to people who don't have a disease, and as our diseases become less common, in general, we're giving them to people who probably weren't going to get the disease on average. These need to be really safe. And I think I'll be able to convince you, but the vaccines that we have now are very safe. They don't always work perfectly, but they are safe. The other thing that I will point out as we go through some of the vaccines is that we've traditionally considered vaccines to be inexpensive and a great public health advance. If we're thinking about really the amazing public health advances of the 20th century, I think many people would put vaccines on that list. So for example, the polio vaccine, an amazing public health advance, almost getting rid of an incredibly deadly and terrible disease from the 20th century, which now is only present in about 4 countries with only a few cases a year. But as we're starting to target less common diseases, and as the vaccines are getting more expensive, they may still work and they may still benefit people and be safe, but it's hard to call some of them cost effective when you think about what you're getting for the dollars that you're investing with the vaccine. And we'll talk about where we are with some of that. There are a number of new vaccines and then some new indications for older vaccines, and so I'll go through some of those. So you'll be happy to know that I am not going to go through this entire list, although you are welcome to ask questions about the vaccines that I'm not going to cover. But these are the diseases with vaccines that are generally available in the US. Many of these are not recommended for everyone, and they're not recommended for all ages. But if somebody needs one of these vaccines, they can generally get it. As we go through this, I will on my slides, you'll see that there are a number of resources, and they're included in your bibliography, and most of those are journal articles. And if you're ever feeling that you have terrible insomnia, please feel free to reference those journal articles, and you can go back and look them up, and it will probably be very effective in curing your insomnia. But what I actually think is probably the best resource, and this is both for healthcare providers and for the public, is the Centers for Disease Control and Prevention website. And you can see it here. And that's actually an incredible repository, at least in the US, for recommendations in the US for how we use our vaccines and the data, if you want to look up any of the data behind the use of vaccines. It takes a little patience to navigate this website. It's not always easy to find what you want right away, but if you are willing to invest a little bit of time, almost everything you need is probably there. So what I'm going to cover today, I'm going to give a little reminder about measles and mumps, because even though we've had vaccines for both these diseases for a long time, they turn out to still be important. I'm going to talk a little bit about hepatitis B. I'm going to spend some time on the 2 pneumococcal vaccines, because one of them is actually new for adults. We'll talk a little bit about the meningococcal vaccines, and as we go through these diseases, I'll remind you, if the diseases aren't familiar, what the diseases are. We're going to talk a little bit about the vaccine for whooping cough, spend some time on the flu, talk a little bit about the virus that causes both chickenpox and then can later reactivate as shingles or zoster, and the vaccines that are used for those. And then we're going to end with one of the most exciting new vaccines, the Human Papillomavirus vaccine. So I don't know if anybody recognizes this picture. Does anyone know who this is? Yeah? It is. This is Andrew Wakefield. So that's exactly who he is. And in fact, Andrew Wakefield is a former British surgeon. And you may have heard his name, and if you haven't heard his name, you may have heard his story. So he published a paper in The Lancet, one of the main medical journals in the UK, in 1998, where he described a link between the measles, mumps, and rubella vaccine and autism and inflammatory bowel disease. And this caused a huge stir because, autism rates seemed to be rising, and parents were very concerned because, you vaccinate your kids with this vaccine kind of close to the time when, if autism is going to be diagnosed, when it's usually picked up. And so, this was pretty horrifying that a vaccine might be causing autism. But it was interesting because other scientists were unable to replicate his findings. And then, in fact, when it was investigated, it turned out that he made up his data. He invented it. It was fraudulent. And the journal retracted it. And in fact, Wakefield was barred from his practice, from medical practice. But unfortunately, even though it's been, with numerous studies now, determined that autism and the measles, mumps, and rubella vaccine, and in fact, no vaccine has a link to autism. Vaccines are not perfect, as I said, but one thing that they don't do is they don't cause autism. But the damage was done. And there was a corresponding drop in MMR vaccination rates, and there continue to be ongoing outbreaks of measles and mumps in the UK. And in fact, many of the cases that we see in the US are actually linked to importation from the UK. So this is just a reminder that measles is still out there. It's been very common still in the developing world. It's very effectively prevented by vaccination. 2 vaccines are, which is how we prevent measles, is we do it with 2 doses of measles-containing vaccine, is more than 95% effective in preventing measles. And from 2001 through 2012, the annual median number of measles cases in the US was about 60. And there's no transmission of measles ongoing in North America, actually. All the cases basically have a linkage to somewhere else. And then in 2013, through August 24th, it was reported in the MMWR that there was a jump, 159 measles cases, which is a lot for us. 99% were clearly associated with importation from abroad. There were 2 cases where the source could not be definitively established. And because this vaccine is so effective, if people had been vaccinated, they would not have gotten measles, and 91% of the cases were in fact unvaccinated or had unknown vaccination status. And one of the saddest things about this is the people who are harmed from this are often children under the age of 12 months, because we don't usually vaccinate against measles until you're a year old, because the immature immune system, it's not clear that it is that the vaccine is not dangerous less than a year old, but it's not clear that it's effective. And when we want to give it, we want to actually have lifelong protection against measles. And so a lot of the people who get measles are young children, and they're unvaccinated because they're not old enough to have received the vaccine yet. But in fact, it's babies who have the highest complication rate from measles, both from when they have measles, and then there are also some late complications of measles that are more common if you have measles at a young age. So this is, I think, just a cautionary tale for all of us that vaccination continues to be important, even for diseases for which we've had vaccines for a long time, and we know that it works, because the measles outbreaks that we've been having in the U.S. really come from a failure to vaccinate. But I want to contrast that with another disease that many people in their mind associate with measles, although it's probably not quite as dangerous, which is mumps. And many people in this room probably remember mumps. If you're born in 1957 or before, you're almost certainly naturally immune to mumps, because mumps circulated widely. But mumps outbreaks have also occurred in the U.S., and they've been a little bit different. And as an example, there was a very large mumps outbreak in 2009 that started at summer camp. There were about 3,500 outbreak-related cases. This was actually similar to an outbreak that had occurred a few years earlier on college campuses in the Midwest, where there were about 6,000 cases of mumps reported. And it turned out that most of the people in these mumps outbreaks in the U.S. had received vaccine. And in fact, they'd received the recommended number of doses of vaccine, 2 doses of mumps-containing vaccine. And the same was true in a 2011 outbreak on our UC Berkeley campus. 29 cases were reported there, and 3/4 had documented receipt of 2 doses of MMR vaccine. So what has happened here? Well, it turns out that mumps vaccine isn't perfect. It's only about 90% effective. So even if you're vaccinated against mumps, there's still a chance that you could get mumps. And most of these outbreaks did actually start with a case coming from abroad, but then it turned out that it could be transmitted even in a population that had received mumps vaccine like it was supposed to. And it's usually because of very close transmission, often in a school setting. So this is an example of an imperfect vaccine. However, on the plus side, we have many, many fewer cases of mumps than we did before we had the vaccine. It is about 90% effective. And the other good news is when people went back and they looked at these cases in people who were vaccinated, they tend to be very mild. So there's almost nobody who was hospitalized because of mumps, and there were very few complications. So we wish the vaccine was more perfect than it is. It's still pretty good, and people are wondering if it might actually be better if we give 3 doses of a mumps-containing vaccine instead of 2. And that might be the future, but it is what's being done in outbreak settings. Okay, so turning from some older vaccines to a vaccine that's a little bit newer, there's a new recommendation for the hepatitis B vaccine that affects adults. So just to remind you about the 3 main types of hepatitis viruses that we see in the U.S. So the first one, and these, you can use the alphabet, they're A, B, and C. So A is the one that you get vaccinated for if you're traveling to the developing world. And it's the one that we used to give gamma globulin shots for. So you didn't get hepatitis when you traveled. But fortunately, several years ago, a very effective vaccine was developed, and people don't really need to get gamma globulin anymore. They can just get hepatitis A vaccination. And nothing has really changed with the recommendations for hepatitis A, so I'm not going to specifically go over it, but it is a universal childhood vaccine. So all the kids are getting it now, and rates of hepatitis A in the US have dramatically decreased. So that's hepatitis A. The other hepatitis I'm not going to talk about is hepatitis C, because this is a vaccine talk, and unfortunately we don't have a vaccine for hepatitis C. But hepatitis C is the hepatitis virus that is spread mostly by blood and blood products. People can get it. The highest rates are in folks who are injection drug users who share needles, but there are lots of people who have hepatitis C who don't have that as a risk factor. And it's one of the most problematic types of hepatitis in the US, partly because we don't have a vaccine for it. But hepatitis B, the one in the middle, we do have a vaccine for, and it's a very effective vaccine that we've been giving to kids for a number of years now, and rates of hepatitis B in the US have also been falling. We were not routinely giving this vaccine to adults, though, because hepatitis B virus is spread in a couple of different ways. It can be spread by blood and blood products. It can be spread by sexual exposures, and it can also be spread by mother-to-child transmission. If the mom has hepatitis B, she can pass it on to her baby. But we didn't think that adults without particular risk factors, if you didn't have risk factors for exposure to blood and you didn't have sexual risk factors, it wasn't thought that adults really needed to be vaccinated for hepatitis B. And then it turned out that there is a higher risk for hepatitis B in adults between the ages of 19 and 59 who have diabetes. And the risk is estimated to be about twofold higher than the general population. Well, why is that? Well, I'm the hospital epidemiologist at our hospital, which means that I'm kind of responsible for trying to control infections. So this is very upsetting to us because presumably the reason why diabetics get more hepatitis B is related to blood glucose monitoring the blood sugar, and it probably is in healthcare settings, and it's probably because we're not doing as good a job as we should at cleaning our equipment, and hepatitis B is very transmissible. So we certainly need to work on that, but we can also protect folks with diabetes by vaccinating them against hepatitis B. Well, why this recommendation to stop at age 59? Well, actually, people with diabetes who are 60 and older certainly can be vaccinated. There's no reason they shouldn't be vaccinated, but it's not specifically recommended because the increased risk wasn't seen in this age group. And why is that? I don't know, because actually, as you get older, you get more diabetes, and certainly as you get older, you tend to be making more visits to see your healthcare providers. So it may have to do with higher levels of pre-existing immunity, possibly, in our older patients, although hepatitis B has not been as widespread in the United States as it has been in other places. So, for example, in some Asian countries where the rates are very high. So I think we don't totally understand why this is, but we do have a tool for protecting people who may be at increased risk. So I'm going to turn from viruses, and now we're going to talk about our first bacteria, which is called Streptococcus pneumoniae, or the pneumococcus. And this is the most common bacteria that causes pneumonia. The lung infection. And so many people refer to this vaccine as the pneumonia vaccine. And this is a vaccine that's been around for a long time. It's actually been around since the 1980s. It's one of our oldest vaccines that hasn't undergone any changes. And so we've been vaccinating people with this vaccine for quite a while. If you're age 65 and older, if you have any trouble with your heart and lungs, if you have diabetes, liver failure, or kidney failure, because all those things put you at increased risk for pneumonia. If you don't have a spleen, because that also puts you at increased risk. Any problem with your immune system. Cochlear implants, because of the risks for meningitis with this organism, because of the wire that goes into the inner ear. And then certain native populations, for example, living on reservations and residents of long-term care facilities, are also at increased risk even if they're younger and they get this vaccine. However, in 2008, there was actually a new recommendation that came out that adults who are younger who have asthma should also be vaccinated, and that smokers who are between the ages of 19 and 64, so they're too young to get the vaccine just based on age, should actually also get this vaccine because of a 4-fold greater risk for pneumococcal disease. So if we didn't have enough good reasons to try to get our smokers to try to quit smoking, now we also have the risk of pneumonia to add to that. So that is the polysaccharide vaccine called Pneumovax. However, there is another vaccine that has come out to make things just a little bit more complicated. And this is a protein conjugate vaccine that we've used in kids. So polysaccharide vaccines take the outer sugars of the bacteria and they package them into a vaccine that we give to people so that people will make antibodies against it and hopefully do a good job fighting off the bacteria. But polysaccharide vaccines have limitations. So when we think about the immune system, there are different parts to it, and making antibodies is only one part of it. And it turns out if you want to make a really effective vaccine, it works better if you stimulate multiple parts of the immune system and you get other cells involved, not just those that make an antibody response. And so the polysaccharide vaccines only get the antibodies involved. And one of the disadvantages of the polysaccharide vaccines is that they don't decrease the amount of time that people carry the bacteria. So you can actually carry the pneumococcus, this bacteria that causes pneumonia, in your throat and in the upper part of your nose. And it can cause pneumonia, and you can actually transmit it to other people. And kids probably do this very effectively to adults. We'll talk about this a few times, but kids are spectacular vectors of diseases. My kids certainly are. And so this vaccine that we've been using in kids, which is a protein conjugate vaccine, has been super effective in terms of decreasing rates of pneumonia and pneumococcal disease in children. And in fact, it's been so effective that it has decreased rates of pneumonia in adults, even without giving them the vaccine. And what it's done is it's decreased the carriage rates of this bacteria in the kids, and that's prevented the kids from giving them to their parents and their grandparents. And so we've seen about a 25% drop in the risk of pneumonia in the United States as a result of this vaccine that we've been giving to kids. So then the question is, well, if this vaccine works so well in kids, should we also give it to adults? Because it's adults over age 65 who are most at risk for disease due to pneumonia and due to this organism. So what do we know about this vaccine in adults? Well, we know that it produces immunity, so you get an antibody response in adults age 50 and older. We know that you usually get better responses than we do with the polysaccharide vaccine if you just measure the amount of antibody that's produced. And there have also been some other studies that show that it stimulates the other good parts of the immune system. And we know that it's well tolerated. And based on these data, the Advisory Committee on Immunization Practices, or the ACIP, which advises the CDC, recommended this vaccine for selected adults in 2012. And the folks that it's recommended for now are people who have immune system problems, no spleen or spleen that doesn't work, A very small group of people who have a problem where their the lining around the brain where their cerebrospinal fluid is has a little bit of hole in it, and the CSF, the cerebrospinal fluid, is leaking out. And that puts you at risk for meningitis. And then again, the folks with the cochlear implants. But that's a pretty small group of people. What about everybody else, and especially people over age 65? So there's now a clinical trial that's going on in the Netherlands. So these other trials looked at, is the vaccine safe? Does it produce antibodies? But it didn't actually look at, does it prevent disease? Does it prevent pneumonia? And this one does, but in order to look at disease as an endpoint, you need a really big trial. So this trial has 85,000 adults who are age 60 and older who were randomized either to get this conjugate vaccine or a placebo vaccine, because they actually don't use the polysaccharide vaccine in the Netherlands. And the primary outcome for this study is pneumonia. And so in a couple of years, we should be able to tell you how well this vaccine works in preventing pneumonia in adults. It won't answer all of our questions, but it may turn out that this is a vaccine that we'll use more widely. Right now, for most adults, they get the polysaccharide vaccine. Okay, so with that introduction to our first bacterial vaccine, we're going to talk about our second bacterial vaccine, which is the meningococcal vaccine. Or it protects against bacteria that's known as the meningococcus, also known as Neisseria meningitidis. So what is this bacteria that may not be familiar to you? So this bacteria is the one that causes meningitis, particularly in young people, so especially in children and in young adults. And if you've heard about a school where somebody died because they had bacterial meningitis, and then they gave antibiotics to a lot of other kids in the school to try to prevent other kids from getting it, it was this bacteria. This bacteria, it's relatively rare that it causes disease. And in fact, even before we had a vaccine for it, the rates in the United States were declining. But it's a bacteria that affects people usually who were perfectly healthy and didn't have anything wrong with them. And it can be absolutely devastating. So it kills people about 10% of the time. But in the 90% of people who don't die from it, many of them have long-lasting problems as a result. So it's not very common, but when it happens, it's really, really bad. So where were we with this vaccine? Well, there's a vaccine that's been around a long time called MenImmune, and some people may have gotten it, for example, if you traveled to parts of the world where meningitis is more common. But this is a polysaccharide vaccine, like the Pneumovax. And so it has the same kinds of problems that polysaccharide vaccine has. And some of those problems has a poor response in young children less than 2 years of age. It has a short duration of protection. And as we talked about with the pneumococcus, it doesn't affect whether people carry the bacteria. So these kinds of vaccines don't really prevent spread to people who haven't received the vaccine. And then the other problem with this vaccine is that type B, which is one of the main types of meningococcus, is not covered. It only covers 4 types, although it does cover the most common types that we see in adolescents and adults. So there are 2 newer vaccines that are very similar to each other that still have the problem that type B isn't covered, but they fix some of the other problems that this older vaccine wasn't able to. So it's a protein conjugate vaccine. We think that it helps to reduce carriage of the organism. It does lead to longer lasting high antibody levels. And there's a good response to boosting. So if your levels wane and you get the vaccine again, you get a good antibody response, which doesn't happen with the older vaccine. So who gets this vaccine? Well, Now, the 11 to 12-year-old visit that kids make to their pediatrician or family doctor didn't used to be that interesting with respect to vaccines. But in the last couple of years, it got a lot more interesting. And I have 12-year-old twin girls, and so they recently went through this. And this is the first vaccine that they had to get that they wouldn't have had to receive before. And it's ideally given at the age 11 to 12 visit. And I'm sure many people can relate to this, but my children are not enthusiastic about receiving vaccinations. In fact, I was telling Jen before this lecture that one of my daughters is still complaining that the flu shot that she got in 2009 is still making her arm hurt. But they had to get this vaccine, and it's the first one we'll talk about that's given at age 11 to 12. Well, if you miss that opportunity at age 11 to 12, you can catch up at high school or college entry, and this is because of a modestly increased risk for college freshmen living in dormitories. Now, it might help some people in the audience to know, in case you know someone who is a perpetual college freshman or never seems to be leaving college or the college dorms, that the risk only seems to last for a year. So once you become a sophomore, or even if you repeat your freshman year and you're staying in the dorms, you actually get exposed to this bacteria relatively quickly, it looks like, and build up immunity. So you don't seem to have an increased risk after that. And the risk is pretty modest. This is still a very rare disease in college students. But it's one of the things that we're trying to prevent with the vaccine. And booster doses are now routine if you get this vaccine as an adolescent or a teenager because you get waning levels after about 5 years. If you get the vaccine as an adult, you don't routinely need to get booster shots because disease is much rarer. So who else gets this meningococcal vaccine? Well, it's given to military recruits, and it's given to travelers and residents who are in areas of geographic risk. And there's an area in sub-Saharan Africa called the meningitis belt, where there's a particularly high risk for getting infected with this organism, and the vaccine is recommended there. Just a few other notes. There's a little bit of age discrimination here because the meningococcal polysaccharide vaccine is still used for those 56 and older if the vaccine is indicated. Why is that? Well, the vaccine is actually not licensed for those 56 and older because it hasn't been tested. There's no particular reason to think it would be unsafe, but it hasn't been tested, so it's not actually licensed and approved to give for those who are older. The good news is, though, for those who are 56 and older, meningococcal disease becomes very uncommon as you get older. We do get exposed to it as we go through life, and this is not a particular problem in older adults. Who else gets this vaccine? Well, you may have heard that there was some reports about people going on the Hajj in Saudi Arabia this year because of concerns about a virus I'm not going to talk about, but the MERS-CoV virus that's circulating in Saudi Arabia that's causing some problems and just might have a reservoir in camels. And I think Charles Chu is going to talk a little bit more about that in his lecture. There's no vaccine for it. But people who had problems with their immune systems were being recommended to not go on the Hajj this year. But there are vaccines that people can get if they go on the Hajj or Umrah pilgrimages in Saudi Arabia, and one of the ones that they're required to get is the meningococcal vaccine because there have been outbreaks of meningococcal disease in pilgrims. And there's also been an outbreak in New York City among men who have sex with men of a serogroup that's contained in the vaccine, and it is recommended that men who have sex with men who are either HIV infected or have certain behavioral risk factors get vaccinated, or if people are traveling from other places and maybe engaging in behaviors that put them at risk and they're going to New York City, that they should be vaccinated. But there are no recommendations to vaccinate men who have sex with men in other parts of the U.S. because the outbreak seems confined to New York City. Okay, so we think this is a good vaccine. We certainly think it's a safe vaccine. It protects against a very deadly disease, But there's a lot that we don't know about it. And one of the things that I think sometimes surprises people when we talk about these vaccines is we actually don't know if this vaccine works to prevent meningococcal disease. So meningococcal disease is rare. To do a study where you look to see if it prevented meningococcal disease, you would have to vaccinate hundreds of thousands of people in order to look for outcomes. And even that might not be enough. So we have some data that are accumulating that we think that the vaccine works by looking epidemiologically across populations. There are similar vaccines that have been used in other places that seem to work. But for this particular vaccine, we're still gathering data to see how well it works. And then the other thing about this vaccine, as I said, my children got this vaccine. It prevents a deadly disease, but it's expensive. And the disease is rare. So this vaccine was not put into place in some ways because it's an inexpensive public health advance. So by our traditional measures of how we decide if an intervention is cost effective, this one actually probably isn't. It probably works, and we know that it's safe, but actually costs us a lot of money to vaccinate all the people that we're vaccinating and to prevent a few cases of this disease. Okay, so moving from a bacterial disease that's very uncommon to a bacterial disease that is very, very common, even if people don't hear about it now quite as much as they used to, and that's whooping cough or pertussis. And we've known for a long time that pertussis immunity wanes over time. So even if you had pertussis, which is sometimes, I believe in Chinese, the name for pertussis translates to the 100 days cough, which is about how long you cough when you get this disease. You cough for about 3 months. And it is very unpleasant, even if you don't get serious illness from it. And so even if you've had pertussis, and many people probably have had pertussis, your immunity wanes over time. And so we've had resurgence in cases with peaks every 3 to 5 years in the US. And we had big pertussis outbreaks in the US, especially in 2010 and 2012, with a really large outbreak in California in 2010. So we've had a vaccine that acts against pertussis for a long time, and the previous vaccine we used to give was a whole cell pertussis vaccine that was used only in children due to its side effects. So this was basically crushed up pertussis bacterium, more or less. So it had a lot of different antigens in it, or a lot of different things that your immune system could react to, and it produced pretty good immunity. But it also produced a lot of other things like fevers and side effects that adolescents and adults didn't tolerate very well. So we only used the vaccine in kids until recently, when we had a new vaccine that's the acellular pertussis vaccine. And this just has a few parts of the pertussis bacterium in it. And so it actually causes many fewer reactions, many fewer side effects. And this vaccine is combined with tetanus and diphtheria in the tetanus shot. And the vaccine that we use for adolescents and adults is called Tdap. And probably many people have gotten their Tdap vaccine. I know that Jen and I have both gotten our Tdap vaccines because we are healthcare workers and parents. And so it's important that we have gotten our vaccines. So this acellular pertussis vaccine in adults and adolescents, how well does it work? Well, when this study came out, the people in the infectious disease community were really, really excited because this looked really good. And this study came out in the New England Journal, and it included almost 2,800 people between the ages of 15 and 65, and they either got this acellular pertussis vaccine or a placebo vaccine. And they were followed out for 2.5 years, and the vaccine was more than 90% effective in preventing pertussis. So the vaccine was approved. This looked really good. We got it into the vaccine schedule, and we thought, we're going to do a great job in reducing pertussis in the US because now we can give the vaccine to adolescents and adults. Well, unfortunately, it turned out to be not that simple. So when people looked at the California outbreak in 2010, most of the pediatric cases had actually been vaccinated as recommended. And it turned out that the highest levels of disease were in pre-adolescents, especially 10-year-olds. So why 10-year-olds? Well, 10-year-olds had gotten their last pertussis-containing vaccine at age 5. Kids get a vaccine called the Tdap vaccine, which is just a little bit different than the Tdap vaccine. And 5 years later, right before that 11 to 12 visit, when my kids were getting their first dose of Tdap, their immunity has waned enough that they actually turned out to be at very high risk for disease. And there was a very nice study that was done by Kaiser Permanente, and it turned out that people who got the whole cell vaccine, even though it had a lot more side effects, actually had much less risk of getting pertussis than people who had gotten the acellular vaccine. So I think what we can say about the acellular vaccine is it works really well for a short period of time, and it's very safe. So how do we employ it to make it most useful? So it is being given to adolescents at that routine 11 to 12 year visit. So my kids, in addition to getting their meningococcal vaccine, got their Tdap. All adults who are 19 and older should get a single dose of Tdap. And one of the very important things that we can do is we can give this vaccine to adults who have contact with infants less than 12 months old. Because while the disease is a nuisance for those of us who don't want to cough for 100 days, it's actually deadly for children who are under 3 months of age. And in that 2010 outbreak in California, there were 10 infants who died due to pertussis. They were too young to be vaccinated, and they were all less than 3 months old. So, and the only people who actually get this vaccine repeated are pregnant women. So this vaccine is recommended for every pregnancy in the 3rd trimester at 27 to 36 weeks because of some pretty good data now that show that the antibodies can be very effectively transmitted from mom to baby if mom has enough antibodies and protect the infant against whooping cough during the period of life when the infant is too young to be vaccinated and is at highest risk. So, and then there are some other opportunities to vaccinate, including parents, siblings, grandparents who are going to have contact with an infant less than 12 months, and healthcare workers, as I previously mentioned. Okay, and then middle schoolers. So let's we're going to turn away from bacteria and go back to viruses as we start winding down. We have a few other illnesses to talk about. But let's talk about the flu. Certainly on everyone's mind, we're going into flu season. Many people are getting their flu vaccine. And flu vaccine got a whole lot more complicated this year than it's ever been before because we have a lot of new products that people are going to have the opportunity to choose from, and not a lot of guidance yet in terms of which ones may be preferred. And in fact, I'll just cut to the chase in terms of which vaccine you should get. The CDC recommends them all equally. So I will present them to you here, and then you can pick whichever one you want. And in a year or two, we may have some more data on whether certain people should get certain vaccines. So the traditional vaccine is the flu shot. And it's inactivated, so it contains just particular proteins from the influenza virus, but not any particles that can actually turn into virus. And it's always contained 2 strains of influenza A and 1 strain of influenza B, which are different types of influenza. And there are very few contraindications to the vaccine. It's not usually given less than 6 months of age, not because it's not safe, but again, because the immature immune system doesn't get a very good response to it. So I think one of the things that healthcare providers probably hear all the time, and you may have said or heard from family members is, I don't want to get my flu shot because the last time I got my flu shot, I got the flu. Well, I'll just tell you, you can't get the flu from your flu shot. There are a variety of things you can get. So one of the things that is common is your arm gets sore. It is true. If you get a flu shot as opposed to just getting a placebo vaccine, typically your arm does get more sore. I just tell myself, this is so great. I am having such a great immune response to the vaccine. It is making my arm sore. I do not know if that's true, but it makes me happy when I think about it. So you can also get other occasional side effects from the flu. Sometimes people will get a low fever, or they'll feel not so great right after they get their flu shot, but that's actually really quite uncommon. And probably most of the time what happens when people think that they get the flu after the flu shot is there are lots of viruses that circulate all the time, and coincidentally it's the winter time, and you get sick, and it just happens to be around the time when you got your influenza vaccine. And the influenza vaccine indications are for everyone. So everybody who's older than 6 months should get this vaccine yearly. And we hope that we are targeting the right strain every year, because that's really the challenge, is knowing what's going to be circulating each year. So what's in the 2013-2014 influenza vaccine that we're all receiving this fall? It's similar to last year with respect to the 2A vaccines, but there's a new B vaccine, B strain that is in the vaccine. So one of the things that I think comes up for people every year, when they're wondering, well, should I get the flu shot? Should I not get the flu shot? Is how effective will the flu shot or the influenza vaccine be at preventing the flu? And, I wish I had better news. I wish I could tell you that the influenza vaccine prevented 95% of influenza the way measles does. But it doesn't. It works better when you're younger and healthier. And that's one of the reasons why some of the strategies, for example, the Japanese did this for a long time, where they concentrated their flu vaccine in their schools. And it turned out that that was actually more effective than vaccinating the older people who were more at risk for influenza, because again, our children, even though they don't mean to be, are so good at spreading diseases that if they don't get sick, then they don't transmit the disease to other people. But last year, the estimated effectiveness of influenza vaccine for preventing laboratory-confirmed influenza was only about 56%. That was a pretty bad year. Some years are better than that. It wasn't because the strains didn't match. So there was some other reason that the vaccine wasn't working as well. So you can look at this two ways. I am an optimist. So I take the glass half full approach, and I say, well, 50%, it prevented half the cases of influenza. Could be worse. And it is a very safe vaccine. Many years it does better than this, but we do have some ways to go in terms of improving how well we do with influenza vaccination. But it does have efficacy, and that was a particularly poor year. So what might we be able to do to make our vaccines better? Well, this is one attempt, and I'm sure many people have seen this if they've gone to the drugstore, and there's something that says, if you're 65 and older, ask about the high-dose influenza vaccine. So there's one vaccine called Fluzone High Dose that's licensed for those who are 65 and older, and it actually contains 4 times the amount of stuff in the vaccine than regular vaccine does. And because older people don't mount as good an immune response, it was thought that this might actually be more effective. And it turns out if you just measure antibodies that it is more effective, although there are more local reactions, probably because you are injecting more stuff. Does it work better to prevent influenza? Well, we're not sure yet. There has been a press release from the manufacturer that said in a 2 influenza season trial, the high-dose vaccine was 24% more effective in preventing influenza in adults 65 and older than regular dose vaccine. But that's all that they said. They haven't released any of their data yet. We haven't seen the study. It's going to the FDA in 2014. to see if they're going to get an indication, if they can actually say that their vaccine is clinically better than regular dose vaccine. So we should hold off on judgment until we actually see the data. But I, for one, am hoping this is true because we may have a better option for folks who are older who can tolerate a little bit more of the local reaction. So that is one of the many new options for influenza vaccination. What else do you have to choose from? Well, for those people who are needle phobic, and this is only approved for adults age 18 to 64 years, there's actually an intradermal vaccine that's injected under the skin. The needle is about 1/10 of the standard length. Because it's given directly to the cells that start the immune system going, it can actually contain less of the stuff than in the regular virus, than in the regular vaccine, and seems to work just about as well, although local reactions are more common, probably because you notice them because they're close to the skin surface. So this vaccine's probably not any better than the vaccine shot that you get into a muscle, but some people really won't get vaccinated because they're too afraid of the needle, and this needle is so teeny, people say they don't even really feel it when it goes under the skin. So that's also an option. Then there's a common option that's used in kids called flu mist. And this is an intranasal vaccine spray. And this is actually a live vaccine, but it's attenuated. So it's made so that it can't cause significant disease. And it replicates in the nose. And you trade your sore arm for a runny or stuffy nose, which is the most common side effect from this vaccine. And so flu mist actually was the first vaccine to do something new, and it added a second influenza B strain. So now it is a quadrivalent vaccine instead of a trivalent vaccine, and it has 2 influenza A strains and 2 influenza B strains because it's hard to know which B strain is going to circulate. So maybe this will make a difference. There are fewer people who can get this vaccine than the flu shot. And it seems to be quite a good vaccine in kids. In adults, it's about the same as the flu shot. And it hasn't commonly been used in adults, partly because many people do have contraindications to it. So what else besides flu mist, and you have the intradermal, and you have the high dose? Well, now you also have 3 different vaccines that are quadrivalent shots that also contain that second B strain. And those are also available at many pharmacies, although many providers do not have them yet. Is it going to be better at preventing the flu? It might be. We don't have clinical data on these vaccines yet either. And then finally, we have 2 new vaccines that are not grown in eggs. And one is it's called a recombinant vaccine, the flu block. And the other one is grown in different cells besides eggs. Now, these aren't because so many people have egg allergy and can't get the flu vaccine. In fact, almost everybody who has egg allergy can actually get the regular flu vaccine. But the exciting thing about these 2 vaccines is if we have another pandemic, we'll actually be able to make vaccine much faster than we could before, because it takes a long time to grow enough of the vaccine in the specialized chicken eggs. And also you can have a bad shortage of these chicken eggs so that you can't make enough of the vaccine quickly if you really need it. So these are really in advance, mostly because we'll be able to get to the technology much more quickly, and not specifically because of the issue of egg allergy. So lots of choices and no real data yet on which ones will be better, but we're hopeful with all this new technology that we're starting to move in the right direction. Okay, so 2 more viruses to talk about, and then we'll stretch our legs and take some questions. So people probably don't spend that much time thinking about chickenpox anymore because most kids are getting the chickenpox vaccine. And I just wanted to point out that this vaccine that we started giving in the United States in 1995 2 doses are about 98% effective in preventing chickenpox in kids. But perhaps more remarkably, the average annual mortality from chickenpox has declined by a rate of 88% overall and 96% under age 50. So people think of chickenpox, well, you know, chickenpox is a benign disease. Why do we have to vaccinate against chickenpox? But actually, a small percentage of people die from chickenpox. And they're usually kids, and they're usually previously healthy. And they can get pneumonia from the virus that causes chickenpox, and in unusual cases, they can die. So this is a very exciting development that not only can we prevent people from getting chickenpox, but that we've prevented, even though it's uncommon, and most kids who got chickenpox did just fine, and it was really annoying because parents had to stay home from work and try to put mittens on their kids' hands so they wouldn't scratch, and that was the general thing that happened. There were a few kids and then some adults who got very bad disease. And as people probably know, chickenpox is a worse disease in adults. So most adults in the United States are immune, but if you're not immune to chickenpox and you do get chickenpox as an adolescent or an adult, you tend to have much more severe disease than you have as a child. And many of those folks do wind up hospitalized. So this has been a real advance in terms of decreasing chickenpox. But probably something that's more on people's minds is zoster or shingles. And about 1 in every 2 people in their lifetime will get shingles. So shingles is common. And people don't die from shingles, but they're really miserable. And the other really bad thing about shingles is that for some people, that misery is not just confined to the 2 weeks where you have the outbreak and you have the blisters, but you can get what's called postherpetic neuralgia, where the pain actually can last for weeks or months or even years at the site where people had the shingles outbreak. And the complication of postherpetic neuralgia gets more common as people get older. So shingles gets more common as people get older, and postherpetic neuralgia gets more common. So this was a study that also came out in 2005 looking at the shingles vaccine, which is the same as the chickenpox vaccine, except it's more potent. There's more virus in there, and this is a live vaccine. And it reduced shingles by more than half, and it reduced postherpetic neuralgia by about 2/3. And it was pretty well tolerated. Injection site reactions where people would get a few blisters or a little redness at the site where they got the vaccine was the only common side effect. So a single dose of this vaccine is recommended for adults age 60 and above, even if you have a prior history of shingles, because a prior history of shingles, unfortunately, probably doesn't prevent you from getting shingles again, which I really wish that it did. So this is also a very interesting vaccine in terms of the public health consequences, because the vaccine is relatively expensive. It costs about $150. And again, this is not a disease that people die from. But when people have done studies on this, it probably, even if you only look at it from an economic perspective, it's probably worth it for preventing the morbidity that people get from having shingles, which is really pretty significant. There are a few other things about this vaccine that are funny. So if anybody here tried to get this vaccine when they first came out, they might have had the experience of going to the pharmacy to pick it up and then having to run back to their doctor within 30 minutes to have it injected, because it actually, once you reconstitute it, it's not very stable and you have to give the injection after a short period. That's largely been solved because now most doctors don't give it in their offices. They either give you a prescription for it or you just go down to the pharmacy and you say that you'd like to get the vaccine, and the pharmacy gives it to you right there. It's also the first vaccine that was covered by Medicare Part D. Most vaccines that are given to those 65 and older are covered by Medicare Part B. And so for a while, people were actually having a lot of trouble getting the vaccine reimbursed, and that has gotten better. So a few things still to be worked out, but probably a good vaccine, even though it doesn't prevent shingles in everybody. And the new studies have shown similar results to the original study. And then the last virus that I'm going to talk about is the Human Papillomavirus, or the HPV virus, and the vaccine for that. So genital human papillomavirus, or HPV, is the most common sexually transmitted infection in the US. And there are two vaccines. I'm mostly going to talk about Gardasil because that accounts for almost all the use in the US. And Gardasil protects against 4 types. It protects against 6, 11, 16, and 18. The other vaccine, Cervarix, only protects against 16 and 18. Types 16 and 18 are associated with about 17% of cervical cancer. So this is a vaccine that prevents an infection, but by preventing the infection, the main goal is to prevent cancer, which is caused by the human papillomavirus. And although it's not the main intended effect of the vaccine, types 6 and 11 are associated with 90% of genital warts. And it turns out that this vaccine does a really amazing job at protecting against genital warts. And genital warts are certainly annoying and embarrassing to people and common, even if they do not have the same consequences as cancer. So how good is this vaccine? Where are we with this? Because it is relatively new. Well, we know that it has excellent short-term efficacy, close to 100%, in preventing infection with HPV types that are included in the vaccine if you're not previously infected. And that is the main issue with this vaccine. And it's the third vaccine that my kids had to suffer through at age 11 and 12. And in fact, the suffering continued because it's given as a 3-dose series. So they had to come back twice more to get 2 more doses of this vaccine. So you can imagine how this conversation might go between pediatricians and some parents because, you're not really thinking of your 11 or 12-year-old boy or girl as being sexually active, although you certainly are thinking abstractly, hopefully very abstractly, that it's coming in the future. But the problem is that you have to really think about this beforehand, because once people initiate sexual activity, you usually get infected with HPV, at least one strain, within the first year. There is a lot of HPV out there. It's very common, so this is something that we have to think about early. And one of the main groups that this may actually be helpful for is men who have sex with men, who turn out to have higher risks of anal cancer and HPV disease than men who have sex with women. Well, that's a difficult conversation to be having with the parents of an 11-year-old boy in terms of thinking of the benefit, because boys aren't going to benefit from cervical cancer because they don't get cervical cancer. There may be a public health benefit in terms of not transmitting HPV to girls, but boys who may be at risk for anal cancer later certainly may benefit from this vaccine. But again, some challenges in terms of how we are going to deliver those messages. The other thing that could be very exciting about this vaccine is some people may be aware that head and neck cancers are increasingly appreciated to be caused by these same viruses in many cases. And so we don't have data for this yet. When you're talking about a vaccine that prevents cancer, you really have to wait for years to see if cancer is truly going to be prevented. But there's a lot of hope that by vaccinating young people, we will actually start to see a decrease in head and neck cancers as well. We do know that we can prevent pre-cancers, both in the cervix and in the anus. And as I said, this vaccine is fabulous at preventing genital warts. And there have been studies from a number of places all over the world with this efficacy. So still some questions about this. We don't know if it's going to be cost effective. There's no recommendation to change cervical cancer screening based on whether somebody is vaccinated at this time. And the other challenge is the vaccine uptake. So in 2012, about half of girls between the ages of 13 and 17 had received 1 or more doses of HPV vaccine, but only a third had received all 3 doses. And that might look pretty good compared to the 2007 numbers, but it was actually very flat compared with 2011. We're not making great inroads with this vaccine. And the vaccine uptake is much lower for boys, although the actual estimates are still pending. However, we recently got encouraging news from the CDC that HPV infections due to vaccine types, even with this low uptake, have really dropped in 14 to 19-year-old girls, coincident with starting these vaccination programs. So we may not have to get everybody vaccinated to see an impact in virus transmission. And we'll have to see what the ultimate outcome is. So that was my last slide, and I will stop there. Thank you very much for your attention. People should feel free to stretch their legs if they need to, but I'm happy to take questions. And I'll take your question first, yeah. So the question was, I mentioned that there was an overall 56% reduction in influenza vaccine, but can I talk about it by age group? And I'm happy to do that, although it depresses me to do so. Because what I didn't mention was that same study that said it was 56% overall said that for one of the strains, it was the H3N2A strain, in those who were 65 and older, there was only a 9% effectiveness rate. Now that's a particularly low number. Most years it's substantially more than that. It turns out that there was probably some funny ways that this vaccine actually grew in the egg, and it may have undergone some mutations such that the antigen, even though the strain that was picked was a good match to what circulated, the vaccine may not have produced good immunity, and they're using a different seed strain this year to try to get around it because it's still circulating. The numbers were a little bit better, though, when you looked at the other A strain and the B strain. So it definitely goes down with age. And it's one of the reasons why I think many people who look at this with public health eyes think that what we should really be doing is trying to not that we should not be vaccinating older people, because the vaccine is very safe and it's not very expensive, but that what we should really be concentrating on is vaccinating the younger people who have contact with the older people, and that would actually be a much more effective public health intervention in terms of decreasing problems from influenza. Does that answer your question? Yes. The main issue that we think of with rubella, so we see very little rubella in the US. We don't have very much transmission of it at all because we've been vaccinating males and females with a rubella-containing vaccine for a long time. The main reason for giving rubella vaccine is actually to prevent congenital rubella. And so some countries that have had rubella vaccine programs have only vaccinated women because of the risks of giving rubella to infants. And so that's the main reason, because rubella by itself is usually a pretty mild disease unless you get it when you're pregnant. The other thing that I think of it causing is aches in your joints. So when particularly young women get a rubella, they can actually get arthritis with it. Congenital rubella can be associated with a number of things, and I think blindness is one of the things that it can be associated with it. So if mom gets rubella and passes it on to her infant, but I'm not aware of it being an issue in otherwise in people who get it. So that's a great question. So the question is, at UCSF and SFGH, kind of how do we run our vaccine programs? Are they run on a patient goes to their doctor basis and they get the vaccine? Are they run on a institution-wide basis where we give vaccine through the institution? Or are they done in a public health way? And I would say, for the most part, they're done the patient goes to see their doctor and they get their recommended vaccines, but not always. So we do have immunization clinics, and they're given in a variety of places. And so, for example, there are opportunities to get influenza vaccine without having to specifically go and see your provider. And the city and county of San Francisco also has some of those events. But most of the vaccines that we give aren't given at kind of vaccine drives. And that may be a more effective strategy to get it to most people. But I think the other part of your question is how vaccines are paid for. So most vaccines for adults are paid for by health insurance. Or if somebody doesn't have health insurance, they're paid for, by the health entity that's taking care of them. But there are not a lot of mechanisms to otherwise pay for vaccines for adults. There is a much larger vaccines for children program that actually provides substantial assistance and provides most vaccines for free if people can't afford them and don't have health insurance. But it doesn't extend to adults. Yeah. So let me take that question first, and then we'll get to the second part of your question. So the question was, because kids are getting less chickenpox, they're getting the vaccine, do we expect there to be less shingles in the future? Because shingles, of course, is the reactivation of the same vaccine, varicella, that causes chickenpox. And the answer is, we think so, and we hope so. We're not completely sure of that, but the data that we have so far are encouraging. So, and one of the reasons why we don't know quite yet is the vaccine only started being given in the US in 1995. So even the youngest people who got it, and it's given to young children, aren't old enough yet to have gotten a lot of shingles. But they are old enough to have gotten some. So even though shingles is more common as you get older, and particularly more common above age 60, kids and adolescents and young adults do get shingles. They just get it at a lower rate. And so far, the rates of shingles seem to be decreased in people who have been vaccinated. Now, one of the things people have been concerned about is if we are not having a lot of this chickenpox virus that's circulating in the population, and so we're not getting exposed all the time, maybe our immunity is actually going to go down because we're not getting this natural boost to our immune system. And maybe people are going to get more shingles because they're not getting this kind of low-level exposure to the virus that primes their immune system. And people have been very concerned about that. So far, that doesn't seem to be happening. The rates of shingles in adults don't seem to be affected so far by the vaccine in kids. And so far, the people who've been vaccinated, so they've never gotten the varicella virus naturally, have low rates of shingles. But it's one of the things that we'll have to see, and it may mean that people might need a booster of the vaccine. It's certainly a possibility, but I would say that right now the benefits seem to have outweighed any problems. And then the second part of your question.
Yeah, and that is, in the meantime, for those folks that have suffered shingles, how much time between the outbreak and getting the vaccine, especially if you weren't young enough, if you weren't old enough to get the damn vaccine when you would have liked to?
Yes. So I hear this from a lot of people who have had shingles when they were younger. They say, I want the vaccine now. And it is licensed for age 50 to 59, although it's not specifically recommended by the CDC until age 60. And the reason it's not specifically recommended is, again, it's relatively expensive. Shingles is more common as you get older, and postherpetic neuralgia is more common as you get older. But you can get it at age 50. However, it's highly likely that you'll have to pay for it because it's not specifically recommended by the folks who do make those recommendations. But then the question is, well, if you've had shingles and you want to get vaccine, how long do you have to wait? And we don't really know the answer to that. The recommendation that I always give people is to wait at least until the rash completely goes away and you're not having any symptoms at the site anymore, mostly because occasionally you get side effects from the vaccine and you just don't want to be confusing that with what you're getting from your shingles. Some physicians recommend that you wait 5 years in between because they think, well, if you got shingles, that should have boosted your immune system. And it's not very likely that you'll get shingles again for the next few years, and so they recommend that people wait. Unfortunately, there's not a lot, it makes sense, but there isn't a lot of data to support it. The rate of shingles doesn't necessarily seem to go down after having a bout of shingles. But one of the reassuring things that I can tell people who are younger than 60 is most people who've had shingles under age 60 aren't going to get it again for a long time, whether or not they get vaccinated. Yes. Yeah, great question. Can you get, the shingles vaccine's a live vaccine, so can you get shingles from it? Almost never. So when people have looked to see in people who get shingles after getting the shingles vaccine, they've actually, opened up the vesicles and cultured the virus and done tests on the virus to see, is it the virus from the vaccine or is it natural virus? And almost all the time it's natural virus. So there are a few cases reported of people getting very mild shingles from the vaccine, but it's really, really rare. So the question is, if you have an allergy or a bad reaction to one vaccine, like the tetanus vaccine, what does that mean for having a reaction and not being able to get another vaccine? So the tetanus-containing vaccine, which is sometimes the TD vaccine, the tetanus and diphtheria, and sometimes the Tdap vaccine, tetanus, acellular pertussis, tetanus, diphtheria, and acellular pertussis, they're bundled. So if you can't get the tetanus toxoid, then you won't be able to get diphtheria and acellular pertussis. But most people who have a reaction to one vaccine, and tetanus is a common one to have a problem with. People can especially get a very sore arm, or it's sometimes referred to as an arthus reaction, where they'll get a lot of swelling. And I don't know if that was your reaction or not, but there are a number of people who really aren't able to get the tetanus vaccine. I am not aware, though, of a contraindication between the tetanus-containing vaccine and the pneumococcal vaccine. So I would have to look that up and see if there is a contraindication, but most of the time there's not. Most of the time, if there's a particular vaccine you can't get, it does not prevent you from getting other vaccines.
My doctor did look it up and she said I can't have this other one either.
Okay, and it may depend on the specific reaction that you had. I'm sorry, I'm not really, with a lot of swelling. That may be a very cautious response, and it might be worth looking into that again, but I just don't have the data to actually give you a great answer. I'd have to look it up. Yeah. So in my talk, the comment was that I had mentioned several different types of vaccines and different types of immunity, and the request was to explain a little more about what they are. And so, in the interest of time, I'll try to be brief. And in the two main types of vaccines that I was trying to distinguish between with the bacterial vaccines are, one is the polysaccharide vaccine. So that's the one where you build an immune response to the sugars on the outside of the bacteria. And the other one main type is called a protein conjugate vaccine, where you take the thing that you want to make an immune response to and you actually attach it to a protein instead of giving it by itself. And the two main types of immunity that we're talking about with the vaccine, so one is the antibodies, and the other one is called cell-mediated immunity. And so what you're trying to do, just very briefly, is that you have B cells that turn into plasma cells that make your antibodies that you want to stimulate, but you'd also like to stimulate the other arm of your immune system that works together with your B cells, and that's your T cells. And that's the component of cell-mediated immunity. And so really, really good vaccines, like some of the vaccines that we have against viruses like measles, probably stimulate both sides of the immune system and give you very high antibody responses, but also make your T cells react against the organism that we're interested in vaccinating against. And so that way you get very long-lasting immunity.
And the acellular vaccines that you mentioned?
Yeah, so the acellular pertussis vaccine doesn't actually quite fall into either of those categories, but it actually contains a couple of particular proteins that are found in the pertussis bacterium. And it may not be enough. It may be that the complexity of the immune response was better and longer lasting when you gave more stuff for your body to have an immune response to. But it doesn't specifically fall into either the polysaccharide or the protein conjugate category. Yeah, great question. And Janice Louie will probably go over this a little more next week. But the question was, having known someone that got pneumonia immediately after the flu, is there a link? And yes, there is a link. So people can get pneumonia either directly from the flu virus, and that is one of the complications of pneumonia, but people can also get bacterial pneumonia after having had the flu. And usually they get the flu and they're kind of starting to get better, and then they get worse again with a high fever and a bad cough. And the particular bad actor, actually one of them is the pneumococcus. So that first bacteria that we talked about that we try to prevent with a pneumonia vaccine can particularly cause disease after influenza. The other bacteria that can do it is a bacteria you've probably heard of called Staph or Staph aureus, and that can also cause pneumonia after influenza. So really interesting question. So the question is, all these vaccines that we talked about have a particular population that we're targeting. And as healthcare professionals, we try to target as much as the population as we can. And so the question was, do we really need to get 100% of the population targeted, or would a smaller percentage be adequate? And the answer to that is, except for a few childhood vaccines, we are nowhere near 100% for any of our vaccines. In fact, our rates of vaccination for adult vaccines, they are terrible. We do better over age 65. And in fact, we do better with age-based recommendations. So when you look, for example, at people who are under age 65 with heart disease and whether they get a flu shot, whether they get the influenza vaccine, it's a very small percentage of the recommended who do. But the answer is, do we need to get to 100%? For most diseases, we probably don't need to get to 100% to get herd immunity, depending on how effective the vaccine is. And this has mostly been described for viral diseases where we have very effective vaccines. But for example, to maintain measles immunity, which is kind of our prototype effective vaccine, we think we need about 95 or 96% vaccine coverage. So you need a high level, but it probably doesn't have to be quite 100%. When you're talking about vaccines, though, that are much less effective, even if you get 100% of the people covered, you probably aren't going to stop transmission of the disease, although you may be able to decrease it quite a bit. Sure. Yeah. So the question is, if you didn't get a vaccine, particularly talking about the mumps vaccine, what are the symptoms of mumps, and would you have immunity, just from being around? So the symptoms of mumps are mostly swelling of the salivary glands, particularly the parotid glands, which are right here. And I think you probably have historically seen pictures, and I think I had one of people with, kind of things tied around their head because they had a lot of swelling of their salivary glands. But you can get swelling, for example, of the testicles in men, and you can also get ovarian inflammation in women. So there are some other complications, and there are rare complications like abnormalities of the brain that can occur with mumps, and so you can get inflammation in other areas too. But in terms of whether someone would be immune to mumps or not, there are a lot of people who can be infected but have a subclinical infection. So in fact, people who were born before we had the vaccine, some of them may not remember having mumps, and in fact, they may not have had a disease that was ever recognized as mumps, but it is possible that they were infected with the mumps virus and actually do have immunity to mumps. And that's something that can be checked if it's ever relevant with a blood test. But you don't get it by just hanging around if you didn't actually get an infection, but you can have been infected and not known it because you may not have had any symptoms. So the question is smallpox totally gone now? Yes. So there are only two infectious diseases that have been completely eliminated, and the human one is smallpox. There's also an animal disease that I believe has been completely eradicated. But the last case of smallpox was in the 1970s. So the only smallpox that there is now is in laboratories, but there have been no cases, human cases of smallpox since the 1970s, and there's no animal reservoir. So the question is, do we vaccinate kids today? We don't. There is still smallpox vaccine, and of course people are concerned, could it be used in bioterrorism, because there are still some of these stocks around. There are people in the military who get vaccinated, and there are stockpiles that are available. After the anthrax attacks, there was interest in getting particularly some more healthcare workers who might be immune to smallpox, and so some healthcare workers actually were given smallpox vaccine. There's a number of problems and side effects with getting smallpox vaccine, so it's not completely straightforward, but there is vaccine around if we needed it. If there are people, though, who have been vaccinated against smallpox, those vaccines probably last for a very long time. And so people who did get childhood vaccines are probably protected against smallpox, and they're also probably protected if they ever needed another smallpox vaccine from having complications from it. So it mostly seems to occur in people who have no immunity.
Hearing H, a digit, N, a digit.
Yeah.
What does that mean?
Yeah, sorry. So, and you'll hear more about that next week when Janice talks about influenza, although I'm sure she'll do a great job explaining it. So the H stands for hemagglutinin, and the N stands for neuraminidase, and it's the way we type influenza A viruses. And they are both surface proteins, so they're on the surface of influenza. And they're some of the things that our body makes antibodies to. And so we use them in our vaccines. And so that's the H is hemagglutinin and the N is neuraminidase. But those are long words, and so we just say H and N. All right, I think everyone is getting restless, and so we should end. Thank you very much.